Okay, so this is an introductory presentation, but I think even the seasoned veterans will see a couple of slides and diagrams that they may not have before. We're going to start with some basic level setting, move into what are quality measures and what are the reporting programs in use today. And then I'm going to briefly introduce the two quality projects that MiHIN is most involved in, namely the skimmer and the PPQC project. And we'll dive into what all that means soon. So what are quality measures? This is the CMS definition. We're trying to quantify healthcare processes, outcomes, patient perceptions, and organizational systems. So you've heard of the global shift moving from process-based measures to outcome-based. So process being, did you perform the service that you were supposed to? Outcomes being, how is the patient doing? So this is really just to introduce the three major stakeholders. You have the patients and providers, which is what you would typically associate with high quality care, but also the payers who are interested in not only high quality care, but also the cost and efficiency involved. And what we're really trying to get toward is the triple aim in the middle. So that's better outcomes, better patient experience at a lower cost. So why quality measures? We are, again, trying to achieve the triple aim together. Quality is at the center of the transformation from volume-based fee-for-service care to quality performance-based accountable care and payment models. Obviously, quality measures can help identify gaps in care where we can really make some improvements, and even some of those improvements can happen while the patient is on site if we reach our goal of real-time feedback. So I know this is hard to read. This list keeps getting bigger. This is the cheat sheet Rick was referring to. But this lists some of the measure sets that is the reality for providers these days. So ECQMs is most associated with meaningful use. Remember, there's the Medicaid EHR incentive program and Medicare. They're two separate programs that providers must choose between. PQRS has been around for about 10 years, and that's the much larger measure set of almost 300 measures, and that's the physician quality reporting system that has a lot more specialty-oriented measures to select from. The Medicaid core sets are assembled by CMS, often with voluntary reporting from state Medicaid programs. A lot of their measures actually align more on the HEDIS side. CPC Plus is a new one that you've heard about, slated to start next year. And that's the one with the two tracks with the risk-adjusted per patient per month payment model. HEDIS, we all know and love. That's been around since 1991. And over 90% of health plans are reporting to it. So it really is the gold standard in quality measurement. The QRS is a new one as well. That's the quality rating system. Any health plan offered on the marketplace, whether a state or federal level, must report to this, and that information will be publicly displayed. The AHIP CMS core set, this is a recent one as well. This one was announced in February of this year, and this was where CMS sat down with stakeholders from across the country to come up with a set of core measures that will be rolling out in MACRA MIPS and in other programs. Honorable mention for PPQC, which is the initiative we started, and we'll dive into that later. So what are some of the issues in the quality landscape today? And these are just some of many. First of all, measure alignment. So not only amongst those major sets that we talked about, but also, for example, with incentives. So Payer 1 might incentivize these 5 measures one year, but Payer 2 is incentivizing a couple of those and then other ones. So what are physicians supposed to do in terms of priority? Provider burden. This is really the biggest one that we're all trying to solve. We do want to measure quality, but we also want to be sensitive to the burden that providers have to face along with their staff, and more on that in a moment. There's a lot of variation and non-standardization of the data flow process from submitting your file, what format to use, where to store it and aggregate it, how to calculate, and how to essentially submit your files. Everyone kind of has their own process and data flow, and there's not a whole lot of national standardization. And finally, on the return trip, the performance feedback data is often not actionable for various reasons. The data is fragmented from multiple sources, it's out of date, the return cycle can take months, and we need to work on that as well. So this is to back up the physician burden piece. This was an article that just came out by Health Affairs, and they essentially concluded that over $15 billion is spent annually in staff alone. This does not include technology expenses at all. And this is frontline staff in terms of the receptionists all the way through to the doctors, and spending time typing the data, cleaning it up, and then hunting for quality information that the payers want to follow up on. 81% of these people also reported that this is more effort being spent than just 3 years ago. So there's an ever-increasing number of measures and measure sets that have to be dealt with. So not surprisingly, the conclusion by the authors that I think we can all agree with is that we need to put more effort into standardization and making them easier to report. So this is the Venn diagram. As we've added more and more measures recently, it's gotten a little less accurate, but we're going to dive into the specific numbers. So this is just a loose approximation showing some of the overlaps and the number of measures within each set. I'd also like to draw attention to the overlap. At the very center of all of that jumbled mess is 3 measures that actually run across all of those measure sets. Those include breast cancer screening, cervical cancer screening, and controlling high blood pressure. So let's dive in just a little deeper. These are the actual number of measures that overlap in between all the different sets. So just to draw attention to a couple areas, I don't think the laser pointer works here, but you can see Medicaid and QRS intersect pretty heavily with HEDIS, as well as CPC Plus at the bottom there. 18 of the 21 measures are ECQMs, so that's another notable one. Let's take another look at this in percentage. So this one's a little more difficult to interpret, but essentially you take the percentage. So, 52% of CPC Plus measures are contained in that top row there. So again, you can see the highest overlaps are the CPC Plus at the lower left corner, overlapping with ECQMs, as well as QRS and Medicaid overlapping with HEDIS quite a bit. So let's dive into one of those 3 measures that overlap all of them that I mentioned. So controlling high blood pressure. This one is taking a look at your hypertensive patients as the denominator. You can exclude those with kidney issues and pregnancy. And then what you want is your patients to have their most recent blood pressure reading be under 140/90. The reason this is highlighted in red, however, brings us to one of our other concerns in quality measurement, and that is variance in specification. So the HEDIS version of this measure allows for your elderly patients, 60 to 85, to have a slightly higher blood pressure, and that's still considered in the numerator. ECQM's CMS decided not to allow that. So it's 140/90 across the board. So this brings us to some inconsistency. So even though some of these measures are consistent in name across those measure sets, that doesn't mean it's the exact same measure and calculated in the exact same way. This can be due to variances in the specifications. So for example, this can be due to update lag time. NCQA can release an update to a measure. CMS will not evaluate and reflect that for a year or more. Also discretionary tweaks. CMS may decide, well, we want to make it easier for people to report, right? So we're just going to kind of tweak this little piece of it. Measurement periods can also be misaligned or different. Sometimes exclusions are optional. Some people take them out. Some people decide to leave them in. And of course, the big one is data source. Are you calculating this measure from clinical only, claims only, or a hybrid of the two? So this can lead to an uncomfortable scenario where you have the same measure name, the same doctor, the same pool of patients, but you actually have different performance results. So let's keep that in mind as we talk about alignment of measures. So there's no standard national reporting method to go from beginning to end, right? People are still manually attesting. Very few people are e-reporting so far, but we're trying to increase the adoption of that. And each of these measure sets has to be reported to individually right now. So obviously we're still talking about burden on providers and the numerous different ways they have to report to these different systems. So what are we trying to do in Michigan, and other efforts across the nation, I'm sure, are trying to go for report once. So this concept was actually introduced to me by Dr. Larson 2 years ago at this conference, where he had a whole presentation about it, so I heard you. We are trying to have physicians and their representatives, POs, physician organizations, submit data one time and then be able to route that to all those programs we were talking about. That's the vision, okay? And this is obviously going to reduce workflow burden to the provider. So we can focus initially on the measures with that high overlap toward the center of that diagram, and then expand until we cover all of them. So how are we doing that? We're starting with the base infrastructure of the skimmer service. Initially, state Medicaid, Michigan Medicaid, asked us to help them provide one location where the providers in Michigan in the Medicaid Meaningful Use Incentive Program could submit their measures, get them validated, see feedback about how they're doing, and then eventually submit to the state data warehouse for, to receive their credit for meaningful use. So we started building that, and then we realized with not too much extra effort, we can also offer some additional destinations at the end to report to, okay? And support more than just Michigan Medicaid providers. So we'll do a little diagram of how the data flow works for this. You have your senders, providers, and hospitals, and they can attach a measure payload, any measure payload. In this case, we're focusing on QRDA for meaningful use. They can send either through an HIE, their regional HIE that they may be a part of, or directly to MiHIN via direct. So the QRDA file goes through the direct message to MiHIN. We then validate that file, make sure it's a valid QRDA. We can store it for purposes of display. And if necessary, convert it to a different format. If you want to send QRDA Cat1 files, we can roll those up together into a Cat3. Once they're ready to be formally submitted, we can then send them along to the data warehouse for the state Medicaid program. We can send it to PQRS at the national level, and other destinations that are designated by the provider. And Jason Werner will speak more on this soon. I wanted to give a very brief sneak peek of what we're going to see later on today in terms of the dashboards that we were talking about, the display layer. With MACRA MIPS, this is going to become more and more critical to review your performance and try to get your numbers up as high as possible. So you can view these at the various levels of hierarchy, whether it's the PO, the practice level, or the individual doc level. So, like I said, Skimmer is equipped with these dashboards. Some POs already have this infrastructure in place. In that case, we can send the raw data to them, and they can use that raw data to populate their dashboards. I also wanted to introduce this term of gaps in care. So, this is officially defined as the discrepancy between the recommended best practice care and the care that is provided. So this can be due to missing services. Did you truly miss the service you were supposed to provide to get in the numerator of a particular measure, or is it just missing data? Did you actually perform the service and it just didn't get recorded in the EHR properly and we can't find it in the electronic world? And that's what we really want to try to minimize, because that is the shame when a provider gets dinged on a quality measure for something that he actually did. So gaps in care transitions us into our kind of offshoot of SCIMR, which is the Physician Payer Quality Collaborative, because this is more into the HEDIS side of things, with working with the payers. So this is a collaboration, and you'll hear more about this from Joe Neller from the Michigan State Medical Society, but it's a partnership between MSMS and MiHIN, where we're trying to bring physician organizations to the table and payers to the table, both commercial and state payers, to talk about this HEDIS data reporting process and how to streamline it and make it more efficient. So the goals we all had sitting down are report once. We all agreed that was a laudable goal. Two-way data query, real-time monitoring as close as possible, or at least to reduce this lag time between submitting data and getting feedback. And really to standardize the way we report HEDIS data, supplemental data, and receive back gaps in care to the provider. So let's talk about what the status quo is in the state right now. You have different POs responsible for different EHR systems and populations of providers. The POs do a great job of extracting that raw data and housing it. But then here's where it gets a little inefficient. Each payer wants supplemental clinical data for their HEDIS calculations because it tends to improve scores. The PO has to make an individual connection which each of the payers it wants to give data to and convert this raw data they're housing into the format that the payer wants. So Priority prefers HL7. Blue Cross wants the group to BCN format, which is a piped limited file. And other payers want yet more formats, okay? So each PO is forced to make a decision, is it worth it? Do I want to make this connection and send clinical data? What if I'm only closing a few hundred gaps in care? Is it worth it? On the return trip, so the payer receives this data, they run it through their calculation engine, they combine the clinical and the claims and run it through their HEDIS engines. And now we want to get that gaps in care feedback to the provider so they can take action on it and improve the quality of care they're delivering, as well as their scores. So each payer thinks they have a really good portal, and they are. They have really nice displays and all of that. The problem is it's fragmented, so getting it back to the provider is difficult in that each provider might have 4 or 5 different portals to log into. They might have printouts and emails and PDFs of this fragmented gaps in care with their patients spread out among the payers. So that's a very inefficient way to take action on that. We mentioned the lag time. Often the lag time from when you submit your supplemental data until you get it back and you can look at the report can be 3 to 6 months, if not longer. That's unacceptably too long, and by that time, you've often already closed the gap in care, or it's just completely irrelevant. You might not even have that patient anymore. So this is what we're trying to move toward. This is the vision of PPQC, and this is one location where you can send one format of file to connect all the stakeholders in this process. So on the initial trip, we want physician organizations and practices to send one file which contains all payer, all patient data, regardless of who that patient belongs to. They send that file to MiHIN. We then filter that and send it to the appropriate payer based on membership files that we receive from the payer, whether that's state Medicaid or commercial payers. Then, once the payers have calculated their gaps in care, they can then submit that raw data about the gaps in a standardized way, and then MiHIN can distribute that back to the providers. So that way, you can envision providers having one aggregated gaps in care report, which is going to be a lot more actionable from an all-payer perspective. So the value proposition for the PO is to make one connection, and the smaller, for the payer side, some of the smaller payers are going to start receiving supplemental data that they hadn't before, because the PO simply decided, hey, it's not worth it for me to send you, to make a connection with you and send you data. So there's huge value here on both sides. So this is where we're trying to go. So I'm going to leave off with this really interesting continuum slide that we saw during a ECQM affinity group session, which Dr. Larson, Dr. Kendrick, I believe, were attending, and experts from around the nation were on a call talking about this. And I want to look over at some of the goals, and we felt these aligned very nicely. So on the top chart, you have the data source, right? So a lot of times right now, HEDIS is being calculated with claims only. And in an ideal world, and what Dr. Kendrick was doing, was integrating both clinical and claims data. And then he was also bringing in labs and others. So that's really what we want. We want both worlds. If you jump down to the data source format, QRDA is a standard format specifically designed for quality data to be moved. Cat 1's, patient level, and Cat 3's, the aggregate data. CMS has been pushing this format through the various legislation, and we hope they continue to do so in MACRA MIPS. And if we can standardize around this format as a nation, that would help tremendously in moving quality data. And again, Cat 1, QRDA Category 1, patient level data is the gold standard that we'd all love to move toward. Finally, my last slide, what MiHIN presentation would be complete without a near lethal dose of acronyms. So these are some of the other organizations that I'd just like to acknowledge that are operating in the state that we've been working with to varying degrees, whether we just bumped into them or are actively partnering. So quality is very important to this transformation that we're going through. These services are, Skimmer is now live, and PPQC pilot is well underway with data flowing. So these charts we're throwing up here are real, and people can participate if they'd like to. So if you have any questions, feel free to reach out to me. And other than that, thank you very much. It's okay.
So folks have any questions?
I survived. So.
So how does National Quality Forum and NQF fit into all of this in terms of measure development? I'm not seeing it there, and they are usually a measure developer, but they're not a measure implementer.
Right. So they were left off of the list because they kind of operate as the aggregator and steward of all the measures, keeping track of the different sets. And as these organizations come up with measures, they submit them to NQF, who then reviews and approves them and gives them a number. So I wouldn't say that they are a measure set that people have to report to, but they are very crucial in the development cycle of quality measures and getting them nationally dispersed. So MIPS MACRA does include, I believe, $75 million over 5 years for measure development, new measure development, in areas that physicians see gaps. Oh, there's no quality measure for this specialty, and there's no measure for this piece of care that I think is valuable. So NQF will continue to play a very critical role in that development process.